Ladies and gentlemen, welcome to this webinar sponsored by Medtronic. The subject today will be the contemporary patient management options for atrial fibrillation. My name is W.Davies and it's my pleasure to be the moderator for this session. It's timely to have such a subject review thanks to the enormous number of advances we've seen in this field over recent years that have now been incorporated into updated guidelines and consensus documents, and we'll hear about those updates shortly. There have been advances in AF diagnosis and monitoring with smaller, more easily deployed implantable loop recorders, new anticoagulants as alternatives to warfarin, devices to reduce thromboembolic risk, new antiarrhythmic drugs, and improved mapping and ablation technologies, enabling us to get better outcomes when we ablate AF. We will be paying special attention to that area today. We are especially fortunate to have two leaders in the field to talk to us this evening. We have Professor Carina Blomström-Lundqvist from Uppsala in Sweden and Professor G.Hindricks. Professor Blomström-Lundqvist has had an interest in AF for many years, especially in surgical and thoracoscopic epicardial ablation techniques. She has also organized many randomized controlled trials in the field, with the latest, CAPT-AF, being presented in the late-breaking sessions at the recent ESC meeting in Barcelona. She has held numerous positions within the ESC and EHRA over the years. Professor Hindricks leads the large cardiac department in Leipzig, Germany, where they have one of the world's busiest AF ablation services. He has a very long and distinguished track record of research in this field, especially in catheter ablation techniques, and is the immediate past president of EHRA. After their talks, which will teach us and provide a platform for discussion, we should all be better informed about all of the above advances, the latest guidelines, the evidence behind each therapy, and the indications for when to choose them and when to use them in individual patients. Carina and Get's talks will be broken up into sections, so there will be opportunities for me to take questions from you and to ask the speakers as we're going along. Please send in the questions as they occur to you. And now, please, Carina, can you get us going with your talk?
Thank you. What I will present to you are the main changes in the ESC AF guidelines, focusing on AF management from a rhythm perspective. So let's look at the basic parts with new definitions of atrial fibrillation. In the new guidelines published in 2016 from the ESC, it is emphasized that if a patient with paroxysmal AF is cardioverted during the first 7 days, it is still defined as a paroxysmal AF. And I think this is important because I think it has been a misunderstanding that as fast as a patient is cardioverted, it is per definition a persistent, but that is not the case as long as the duration is no longer than 7 days. Another change was presented in the new AF ablation guidelines, which is a joint guideline between the EHRA and EHRA, and they have introduced a new definition of persistent AF. Persistent AF is known as long-standing persistent AF if the AF duration is greater than 12 months. But the new other subdivision is early persistent AF. And with that new definition, we mean that the AF duration should be less than 3 months. I think this is important if we want to better categorize our patients in studies and registries, because patient selection is of course important in order to interpret the outcomes of the different trials. Having said that, let's look at the other changes. Another important change is the recommendation to always use EHRA scoring. This is a scoring of the patient's symptoms during atrial fibrillation. And as you can recall, EHRA classes were subdivided into 2, 1 with no symptoms and 4 with the most severe and disabling symptoms. So the change is to introduce a subdivision of EHRA class 2, meaning mild symptoms, when normal daily activity is not affected. So 2B score means moderate symptoms without affecting normal activity, but the patient has is troubled by the symptoms. So 2 more score levels. Another change is more emphasis on screening of AF. As you recall from the 2012 guidelines, there was a recommendation class 1 to use opportunistic screening, meaning that you are encouraged to take the pulse, to encourage patients to take the pulse in patients older than 65 years, meaning a risk factor for stroke.
Carina,
yes.
I'm sorry to interrupt, but for people who might not be so comfortable or aware of the classification of evidence and the level of evidence, perhaps you could indicate what class 1 and level B and etc.
Of course.
indicates.
The recommendation classes, we have recommendation class 1, which means that there are trials, randomized trials or large registries supporting such a recommendation, and there is a general consensus among experts that a treatment should be given or a diagnostic workup should be conducted. Then we have recommendation class 2, which is subdivided into 2A and 2B. And in that case, there is some conflicting evidence, with 2A being stronger than 2B, to be in summary. And then there is this recommendation class 3, which means not to do. So the green boxes are recommendation class 1. It's the highest recommendation, meaning that you should adopt to such recommendation. So with regard to screening, it is recommended, as the old guidelines, to encourage people to have pulse palpation and also to record ECG or rhythm strip in patients older than 65 years of age in order to detect atrial fibrillation that may need some further treatment to prevent stroke. Other screening methods are encouraged in patients with TIA or ischemic stroke. It is recommended to record an ECG, or if you don't record atrial fibrillation, it is recommended to continue with continuous ECG monitoring for at least 72 hours. There is also a new recommendation of reading devices with atrial leads and look for atrial high rate electrograms, which are indications that patients may suffer from atrial fibrillation. So if you detect atrial high rate episode, you should try to confirm that this is atrial fibrillation by further ECG monitoring. These are the class 1 recommendations that have been underlined in the new guidelines. The other changes I think worth mentioning are the focus on the detection and management of risk factors and lifestyle modification programs. And the two most important risk factors, I think, is the obese patients, where they have a class 2A recommendation to encourage the patient to lose weight in order to reduce AF burden. And the other recommendation is to look for clinical signs of obstructive sleep apnea, which should be considered in all AF patients. That is also a class 2A recommendation. Then, of course, there are many other risk factors that should be treated appropriately. And another change that was introduced was that recommendation for catheter ablation should not be gender specific. Mm-hmm. Of course, it should be recommended both to females and males. As we have seen in randomized trials or registries, there are more males being offered catheter ablation. 80% are usually males and 20% are female, and that's not the proportion between the males and females with regard to prevalence of atrial fibrillation. So females should be more liberally referred for AF ablation than is seen in trials. Other changes I think that are worth mentioning is that these guidelines put more emphasis on rhythm control as opposed to rate control. Rate control is of course important, but if patients have AF-related symptoms, you should of course consider rhythm control therapy. Antiarrhythmic drug treatment is one of the 2 rhythm control therapies that can be offered patients. And the choice of antiarrhythmic drug needs to be carefully evaluated, taking into account the presence of comorbidities, structural heart disease, and the risk for serious proarrhythmias. A new recommendation is also dronedarone, which is recommended for the prevention of AF episodes in patients with coronary artery disease. This is a class 1 recommendation. Now, if we look at the new recommendations for AF ablation, it is put a lot of emphasis on the use of PV isolation for all types of atrial fibrillation. And if we look at the indications for catheter ablation, we look at this figure. We have 3 types of AF: paroxysmal atrial fibrillation, persistent AF, and the long-standing persistent AF. And as we can see, if the patient fails only one antiarrhythmic drug, there is a class 1 recommendation for catheter ablation. For patients with paroxysmal, there is a class 2A for catheter ablation in patients with persistent AF, and a class 2B for long-standing persistent AF. And this is of course related to the observations that the outcome for persistent AF patients, and particularly patients with long-standing persistent AF, is not as good as for patients with paroxysmal AF, having a very high success rate on long term. These are the recommendations from the AF ablation guidelines that was published this year. And if we compare these recommendations with the 2016 ESC guidelines, we can see that the ESC guidelines are more liberal and have a class 2A recommendation for even for long-standing persistent AF patients. And again, isolation of pulmonary veins using either radiofrequency ablation or the cryoballoon is a class 2A recommendation. So in these guidelines, there is no recommendation to further use lines, café, or to look for trigger activity. Pulmonary vein isolation is the standard golden technique. It is further emphasized to also offer patients that have not been included in the many randomized clinical trials, and the ones that are listed here are patients with congestive heart failure, older patients older than 75 years, patients with hypertrophic cardiomyopathy, younger patients, patients with tachybrady syndrome, and also patients who are athletes. These groups should of course also be offered AF ablation, as there are no studies showing any poorer outcome in these groups. So there's no reason not to include these patients for the same indications. Now, there are other patients that have also been studied in randomized trials, and that are patients who are referred for catheter ablation as their first-line therapy. And in the new ESC guidelines for patients with paroxysmal AF, there is a class 2A recommendation to refer the patient for catheter ablation before trying any kind of antiarrhythmic drug. In the AF ablation guidelines, there is the same recommendation level even for patients with persistent AF, that is class 2A recommendation as first-line therapy. Another recommendation I think it's also important to emphasize, and which will be discussed more thoroughly after Professor Hendricks' presentation of some new randomized trials, is that AF ablation should be considered in symptomatic patients with AF and heart failure with reduced ejection fraction. For these patients, AF ablation is a class 2A recommendation. Another important patient group is the patients who suffer from AF-related bradycardia or who suffers from bradycardia related to the antiarrhythmic drugs. The recommendation is to avoid pacemaker implantation in these patients and instead refer patients for AF ablation. This is also a class 2A recommendation. So the current challenges that we are facing in treating our patients with atrial fibrillation are listed here. One is, of course, to decide when is the best time to refer a patient for ablation. There are two points that are important. That is management of risk factors that we discussed. I think it's important to try to manage risk factors first, promote weight loss in severe obesity, to diagnose sleep apnea, and of course to treat concomitant heart diseases and to check hypertension. Many patients are not well regulated with regard to their blood pressure, and that is important since there is a higher recurrence rate if the patient's hypertension is not well controlled. It is also important to refer the patients for AF ablation before AF progresses with the development of atrial fibrosis and the left atrium becomes too large to be manageable and to have a good outcome. So I think do not wait and refer patients for AF ablation until it's too late. With regard to drug challenges or symptoms to different drugs, the most important thing is to remember is, of course, the safety profile and to exclude structural heart disease. So all patients suffering from AF should undergo echocardiographic examination in order to exclude such heart disease. When to refer to an electrophysiologist? I think that we should have in mind for all patients with atrial fibrillation who have AF-related symptoms. Consider a consultation, a phone call, whenever you are facing such a patient. Discuss the most optimal therapy. Maybe it's even better to start with AF ablation. Maybe it's better to choose a beta blocker before an antiarrhythmic drug. So I think have an open line with an electrophysiologist. So
thank you very much,
time
Carina.
for questions.
That's great. Get, do you have any questions for Carina from that before I take questions that have come in?
Yeah, first of all, just a comment. I believe that Carina very nicely pointed out the key strategic line out of the 2016 AF guidelines, which are pretty much in line with the 2010 and the 2012 update. I believe that it's very important that these guidelines for the first time make the point of opportunistic screening in a patient population at risk, that we can protect these patients and guide these patients safely to appropriate and adequate therapy. The second point that is very, very important is that we continue to follow the lines of patient engagement, shared decision making. The patient plays an important role in the selection of therapy strategies, as quality of life plays a very, very important role in the decision making. And third, it was very, very nicely rolled out that the concomitant disease and the usual suspects and drivers of atrial fibrillation, namely obesity and sleep apnea, play a key role. Do you believe, and I would like to attach my first question to that, do you believe that behavioral changes in obese AF patients can be successfully performed in Sweden? I'm always very impressed when I take a look to the data of Crash Sanders from Australia. It seems that the Australians, which I think on average have the highest BMI on this planet, when they lose weight in the setting of AF, they seem to change behavior and they stay on a low BMI level. Would that be possible in Sweden as well? I have my doubts for Germany, obviously.
I think it's worthwhile to comment the Australian study before answering your question about how it is in Sweden. First of all, that trial was not randomized correctly because the patients that actually refused to enter this lifestyle modification program became the control group. So there is a patient selection. And we know from the RAISE 3 trial that it was very difficult to convince patients to reduce weight. So I think that is the most difficult part. I think we should put more attention to diagnose sleep apnea. We know that is a risk factor in reality, and also hypertension. Many of our patients in our hospital are not well regulated.
So would you send an obese patient who comes with the desired ablation back home for 3 months?
No, I would probably not do that. I would
for the obese patient, should the ablation be delayed until they've lost weight?
I would absolutely discuss overweight with the patient, refer the patient to a dietist, absolutely, and put the patient on a waiting list still.
I would discuss the role of weight loss with the patient, but honestly, at least for the German patient population, I have my doubt that substantial weight loss can be achieved, at least outside specific dietary programs that these patients need to achieve something.
Okay, thank you for that. And you might have to wait before you go back to Australia. But, we touched on the introduction of the possibility of considering ablation for asymptomatic patients. So the question is, do the patients have to be symptomatic to receive an ablation?
Yeah, I think so. As far as we know today, if we disregard the very recent trial on the heart failure population, that is a special discussion that we may come back to when Gerard has presented the result of the CASTLE AF trial. But I think that that patients should have symptoms before we refer the patient to AF ablation, yes.
Leading on from that, how would you define them? Because sometimes we find patients, they say, I'm not aware of this problem at all, but we perform a cardioversion and suddenly their exercise capacity is better.
Absolutely.
So do you consider that as part of the strategy? Cardioversion, sinus rhythm, let's really assess whether there are symptoms.
I think you would have to say that palpitation is not the only symptom the patients suffer from, but dyspnea, tiredness, walking up the stairs and so on. So you have to be careful when you take the clinical history from the patient, how symptoms are expressed. So I think many physicians forget to regard these symptoms.
And do you have a level of frequency for symptoms before you consider an ablation?
I think that also has to be discussed with the patient. What is the handicap for the patient per se?
I agree.
So.
Okay, well, I think that covers that first section. So time to turn to Gert for your presentation, please.